So, Assalamu alaikum, everyone. This is Khalabid here. I welcome you all in our next session. So, a little bit about giving back to pharmacy in Pakistan. So, giving back to pharmacy in Pakistan is a volunteer organization of all pharmacists from around the globe. Our vision is empowered a pharmacist for better healthcare. So, to continue the chain, we are again with our other session, and we have Dr. Rana Kamran with us today. He will be mentoring about study designs and their appropriate application. Before the proper commencement of today's lecture, I would like to share a bit about Dr. Rana Kamran. Dr. Kamran is currently working as an ambulatory pharmacist in ADNOC clinics. He has 8 years of work experience in UAE as community and retail pharmacist. He is trained in infectious diseases, critical care, and ambulatory care units in Thambay University Hospital, Anjuman, UAE. Ajman, UAE. He got his specialization in infectious diseases during master's in clinical pharmacy. He is also a licensed member of BPS. So thank you, sir, for taking out time for today's session. The floor is yours now.
Okay. Can you hear me? Yeah. Okay. So first of all, I will start with the importance of the study design. Why a clinical pharmacist need to study the study design or statistics? What is the reason behind that? If you want a drug information, obviously you need some resources. You will study some of the drug resources, whether this is the pharmacopoeia or anything. But if you don't find it, so obviously you need something else. You try to study or you try to find on the Google. So when you go to the Google, it will give some research articles. So if you know the study design, if you have a scientific background, if you know something about the scientific background, then you can read it properly. You can understand it properly without wasting the time. And this is the importance of the study design. What type of research studies are there? Some are descriptive. They are just describing something. And if we will see about the time orientation, some are about the previous, like in the past. These are some retrospective studies, some are prospective study. What are these? We will study in the detail. Some are not the observational or descriptional. They are experimental studies as well, and some are quasi-experimental studies as well, and observing. So what are these types? First we will get to know. Yeah. So before starting the type of the studies, we'll talk about the validity. Internal validity is about the confines of the study, like you how much the study is internally strengthened and how much it is strong. It will address the biasness, confounding, and measurement of the endpoints. And the external study is related to the generalization, whether I can apply the study on my population or not. Like for example, in the internal study, internal biasness or internal validity, it's all about like whether there is any mistake or error has happened, or they are treated or not treated, and how much your study is strong. Or the external is that can I apply in my population, or can I do the same research, or can I use these results or not. So this is about the validity of the study. So if your internal and external validity is good, then it's mean your study is good. Why I'm telling you this? Because if you are going to study an article, like for example, you are trying to find an article among the 10 articles, you want to find the best one. So how could you know about this article is better than others? If you know the validity, if it has a better internal and external validity, this article is better than others because they have treated biasness. What is biasness? Biasness is like in the common language is like if I'm giving favor to somebody else on the others. So this is a biasness. So same like this might be in selection. I did some error. Might be in selecting the individuals. Might be in selecting the drugs. Might be in selecting anything. This is a selection biasness. And if I forget something, or if an interviewer is asking me when this happened, like I tell him like in the childhood, I have a strong headache, and he asked at what age, and I can't remember this. What was the age at that time? Even I was 7 years, 9 years, 10 years, 12 years. So this is a possible error in the history. So this is a recall biasness. So there is a chance of interviewer bias as well. Might be the interviewer ask me some other questions and he's asking you some other questions, or so that you have seen normally the people who are taking interviews in a study, they write the questions. So why they write the questions? Because they don't want to deviate the questions from individual to individual. So there would be no more biasness. So misclassification of something. So there are some other factors that can impact on the study other than biasness are called confounding factors. What is a confounding factor is actually? Confounding factors are like, for example, if I want to study the alcohol can impact on the coronary artery disease or not. So I'm just looking at alcohol and coronary disease. Now I forget some other factors that can impact on the coronary artery disease, like smoking. Smoking can have an impact on the coronary artery disease, or obesity, family history, like these things which can exacerbate. Like for example, spicy food, it can exacerbate the hyperacidity, or smoking can exacerbate the hyperacidity, but it cannot cause an ulcer. They can exacerbate the cause of ulcer. So we should remember, if we are studying the hyperacidity in a person, then we should see whether he's a smoker or not, whether he's taking spice less or more, what type of food he's taking, junk food, or like he's taking salad or not, like this. So we have to get a better internal validity, we have to control the confounding factors. So we should see in detail if these factors can impact on my study, whether I have dealt with these factors or not. So how can I deal during the design of a study? When I'm designing, I can randomize them. Randomize mean I have 50 individuals. So I just randomly pick 25 in one group and 25 in other. It's not like male 25 on one side and female. No, 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 no. If I do like this, there is no more randomization. If I make educated on one sided, uneducated on other sided, it would be non-randomization. If one age in one group and other age is in another group, then it is not a randomization. So randomization mean to say both groups should have educated, uneducated, both group must have a male and female, both group must have a child and the old. So this is called a randomization. In the randomization, we can fix the confounding factor, or we can restrict something. We can use the matching. Like I can restrict, okay, this study is only for the males, I'm not including the females for this. Or might be I'm using a matching we are using normally for the cohort studies, where we are taking everything is similar between the both of them, both of the group, just one difference. So like for example, the both should be of same age, the both should be of same height, same BMI, with the same gender, with the same class, everything, living standard, and we will see the one have the heart failure and the other don't have the heart failure. Then we will find what is the reason behind them, because both have the same age, same weight, same height, same gender, same everything. Then why there is a difference? And then during the analysis, we can also stratify them. I can stratify whether, like for example, I'm finding the alcoholic person causing, having the this these coronary artery disease. So I will see how much alcoholic with smoking have this coronary artery disease, or how much non-alcoholic or alcoholic without smoking have. So then I will see the impact of the smoking as well. How much men with alcoholic and with smoking have coronary artery disease, or how much men or have smoking and without alcohol, then what is the reason? So this is a stratification. And if there are multiple factors, multiple confounding factor, then we will use a multivariate analysis. This is only we can assess through the SPSS. So there are causality, what is the cause of this thing. We are trying to find out the cause of a relationship, or a relationship. What is the strength? Does it increase the strength of the relationship? Does it there is any biological gradient, like might be if we are increasing the dose, we are having a better effect. If there is any consistency, specificity, plausibility, coherence, all of these are the we can study under the causality. We try to find out the reason behind them. So this is all about the internal validity, the strength. Now I have told you about what type of article you are selecting, why you are selecting one article. Why? Because the strength of this article should be very good. Internal and external validity, confounding should be treated, and then we will come to, and it must have a causality. It shows some causality. A relationship should be there. Now, the relative strength of the evidence hierarchy of the study design. We have a different type of studies. So what type of study is better than other? So the worst or the least one is the ideas, opinions, and reviews. Case series and case reports are on the second. Better than that is cross-sectional. Better than them is case control, then cohort, and the best is RCT. And when we combine a lot of studies and we will get a mixer, this is called a systematic review and meta-analysis. So first we will study the obviously not the idea. We'll start with the case series and case control. So what happened in the case report? Like for example, if one of our patient in a hospital, he get a rare disease or a rare problem or a rare adverse effect from one medicine. So we will report it. We will report and we will write on paper and we will submit it. Why? Because I want to tell everybody. I want to tell the world that this medicine can cause this rare issue. Everybody will know about it. We cannot consider it as a study. We'll consider it as a case report because we report a case. But if there are multiple cases are there, then we will take it as a case series. Then we have some observational studies. In observational studies, we have case control, cohort, and cross-sectional. These three are the observation. What we are doing, we are just observing. We are not giving anything to the patient. So first, we will start what are the advantages. Hypothesis is formed. We can say that this medicine is causing this, or might be we can say obesity is causing diabetes, type 2 diabetes or something. So I can establish a hypothesis. Easy to perform, inexpensive, because you are not giving money to the people. You are just making a survey. You are doing a survey. You are just observing the people. So what is the disadvantage? Obviously it's not a strong study, so it did not develop the association. It doesn't establish the causality. It do not provide the explanation. Why? Because it is an observation. It is not a practical or experimental study. So in this, first of all, we will discuss about the case control. So name is very clear. Normally people are confusing the case control with the cohort. So case control study, its name is that first we will find the cases and then we will find the control, and we will go behind. We will see whether these cases, they have any exposure or non-exposure, or these the people with the without cases, these are called control. So whether they have exposure or not exposure. Like for example, coronary artery disease is a case, and a same person with same factors, he don't have a coronary artery disease, he is a control. So we will see whether how much people have the exposure to the smoking. So smoking is an exposure. How much are the smokers have coronary artery disease? How much have non-smokers have coronary artery disease? Same like this. How many smokers don't have a coronary artery disease, and how many non-smokers don't have a coronary artery disease? This is the way. So this study starts in the past and it ends in the present. Now, right now. So this is called a retrospective study. So we are seeing the exposure and risk factor and disease condition. And classic example is the aspirin used in the Rey syndrome. So this is referred as a retrospective and measure of odd ratio. But in some cases, estimate of the relative risk ratio also. We will discuss it in the future. But odd ratios are only measured. Risk ratios are not measured in the case control. Risk ratios are measured in the cohort studies. So what is the advantage of this? It's an inexpensive, again, because it's an observation, quickly conducted, allows investigation of several possible exposure. Obviously, you will not find a one exposure, you can find multiple exposures. So you can develop more than one hypothesis. So disadvantage is that confounding must be controlled. Observation and recall bias. Obviously, it's if it is retrospective study, always remember the possible bias is the recall, because it is about the past history. So people can forget about the exposures. They can might be they will not remember. Like if I will ask you how many times have you used antibiotics in the last 5 years, so obviously you will not remember this exact number. So there is a recall biasness. Selection bias, case selection might be you select the wrong case. Why? Because it's not like case or control. Obviously you are selecting the right case and right control, but they are not matching. Might be you make an error in the gender or in the BMI or in the ages. So there would be there can be a possible of the selection bias as well. So here you can study. We'll start from the present and it will end in the past. We'll go behind. We're going behind. So these are cases, like for example, these are with the Rey syndrome, and these are without Rey syndrome. We'll see how many use aspirin, how much didn't use aspirin. Without Rey syndrome, same population, how many has used aspirin, how many don't have used aspirin. So this is the classical example. Here is the risk of the myocardial infarction associated with it. This is a perfect article. You can see this is about the case control. You can see the objective is to assess the association. He's trying to find the association. So between the first myocardial infarction and the use of antihypertensive agent. So the patient is using antihypertensive agent. While this antihypertensive agent can cause myocardial infarction or not. So obviously we will take the people with myocardial infarction, without myocardial infarction, will go behind them. How many have used antihypertensive? How many don't have used the antihypertensive? So this is the methodology. These are the result, and this is the conclusion we have to find out. So you can study this article in detail, because normally the exam question they have taken from these articles. So what is the purpose of this study? You're trying to find the association. What is the disease? Disease is myocardial infarction. What is the exposure? Exposure is antihypertensive. Whether this antihypertensive, any class of antihypertensive, like for example, we are studying calcium channel blocker or amlodipine, whether this amlodipine is causing MI or not. So how can I find out? I will run a case control study. So this is how we are doing. So there are the cases mean these 623 people have myocardial infarction and hypertensive who have sustained a first fatal or non-fatal MI. Control are 2032 patients, so it's mean they don't have MI, but they were hypertensive for age, sex, and calendar year. All these cases had pharmacologically treated hypertension, so they all were treated. And so how we are getting the data from the medical record, telephone interviews, and exposures, and using the computerized. So there are obviously there are chances of some errors. There is another study. We will use this study in the next coming uh, after some slides as well. This PPA and the risk of hemorrhage, whether this PPA is causing hemorrhage or not. So we'll see how many people has used. We'll go behind and we will see the people who are having hemorrhage, they have used PPA or not, or the people with the same population, they whether they have like they don't have the hemorrhage, whether they are using PPA or they are not using PPA. This is what we are doing. So the other type of study is the cohort study. Cohort is opposite to the case control. In case control, first we take a case and control, we go behind. The cohort is something different. We will take a population and we will take a sample format. We'll see how much people have risk factor and how much people don't have risk factor. So it's mean how much people are smoker and how much people are non-smokers. And then we will see whether they have myocardial infarction. Smokers, how much smokers have myocardial infarction and how much smokers don't have myocardial infarction. Same, how much smokers, non-smokers have myocardial infarction and how much non-smokers don't have a myocardial infarction. So we are studying everything. But it can be a retrospective and it can be a prospective as well. If it is starting from the past and it's finishing in the present, this is a retrospective study. Same, but it can be a prospective if it is starting from today and we are observing the patient for the future. So you can see the advantage is less expensive, time consuming, and like less time consuming, no loss to follow, and ability to investigate issues, and like it's not no need to do a clinical trial or ethical or safety issues are required. So but the disadvantage same if it is retrospective, recall bias, little control of confounding variable. So what is the prospective benefit and disadvantages are obviously the same. So this is a example of the study. You can find this copy paste this this title, postmenopausal event in the nurses health study, active observational study. So it's a prospective, so it means we are going to follow up the patient. So we will follow up these patients. So this is the background. It's showing the heart and estrogen progesterone replacement study has the first randomized clinical trial of a combined hormone therapy and secondary prevention of coronary event. The trial have overall null result, but reported an unexpected increased risk of recurrent effect in the initial year, followed by the decrease during the final year. So it's been they find something. Even they didn't find anything, but still they find a lot of things. So this is the benefit of a study. A good study, it will tell you something at least. And this is the objective to additional data on the time and trend in the risk of the recurrent heart disease. So what is the design? It's a prospective observational cohort study. Cohort, it's mean first we will take a population. So they take a 2489 post-menopausal woman. So we'll take a sample from the population with previous myocardial infarction or documented arteriosclerosis. 213 cases of recurrent non-fatal MI or coronary heart deaths were identified from this. So then we will divide it whether they have risk or they don't have risk, or whether they will have the disease or they will not have the disease. This is what our whole story is. And in the conclusion, the risk of recurrent major coronary events seems to increase among the short-term hormone users with the previous coronary disease due to the decrease with longer-term use. So that he's not even giving you the association. It's telling you the reason behind also. So this is why this study is better than case control study. So then we have another class is cross section. So cross section is like if I want to know how many COVID positive patients right now in UAE, how many in the Pakistan, then I can identify the prevalence or characters of a condition in a group of individuals. Like how many white people we have, how many dark people we have, how much antihypertensive people in the UAE, what is the percentage of diabetes, type 2 diabetes in the UAE. So these things we tell you about the prevalence of the disease. So this is a cross-sectional study, early design, snapshot in a time. It will give you a fast picture. So you have to just take out the data and you will get the picture. Disadvantages: does not allow you to study a factor individual over the time just at the time of assessment. Difficult to study, and in rare condition, it's very difficult to find. Because for the non-rare condition, it's very easy. So here you can see the example, the prevalence of um, yeah, this is a prevalence. I'm sorry, you can read the full impairment in this population based and cross. So you can see this is a cross-section study where we have another also maternal characteristics and immigrant pharmacotherapy during pregnancy. Cross-sectional analysis of a data from. So there are different type of cross-sectional studies in the internet. It's available. Cohort studies are available. Case control studies are available. So if you know about these studies, if you know this classification, then you can read the article very well. So we will talk about the experimental and RCT, one of the biggest the type of the studies we will talk about. But before that, I want to tell you about incidence, prevalence, risk ratio, and odds ratio. We were talking about these. What is the incidence? Incidence is the measure of a probability of a developing a disease. Like for example, nowadays in Pakistan, you said the incidence of COVID-19 is 7%. So what does it mean? It's telling me that tomorrow 7%, 7 people out of 100, they will have a chance to get positive for the COVID-19. There is a chance, and this incidence is increasing with the time. So if I want to know the rate of incidence, well, what is the rate? Then we will have to divide it with the population. Then we will get the rate of incident. What is the rate of incident? So same is the prevalence. Prevalence is telling you what is actually have it to now at this time. What is the number? So measure of a number of individuals who have a condition at any given time. So if it is point prevalence at any given date, and if prevalence period, like for example, what is the prevalence of type 2 diabetes in Pakistan in 2020? So you have to just see from the 1st January 2020 to 31st December 2020, you will see how many cases are reported with type 2 diabetes. So you will tell the prevalence of type 2 diabetes. So this is how it's a type of I told you about. It's a cross-sectional study. So we want to know about the interpretation of this. Just a minute. I want to move it. Yeah. Interpretation of risk ratio and odds ratio. I talk about odds ratios and risk ratio in the cohort and case control. In case control, we talk about odds ratio. What is odds ratio? Okay. What are the odds of a disease to be happen? So with this risk, like if you have this risk, how much are the odds? How much is the chances you have this disease? And risk ratio is what is in future. What is the risk to get this disease if you are exposed to the risk factor? Like for example, risk factor is smoking. Now I want to tell you what are the odds, how much it does happen, how much it does happen normally. So I'm telling you the odds of event. But if I'm telling you how much chances to get this disease in future, This is the risk ratio. So estimate the magnitude of association. So it is telling you how much is the association. So it's not only in the this case control and cohort study. We're just talking about the association, but we didn't tell about the magnitude of association. How much is the association is stronger? So the magnitude of association is from the odd ratios and risk ratios. So the incidence of disease is exposed group divided by the incidence of the disease in unexposed group. I will just explain. The risk ratio and the odd ratios are interpreted on the basis of their difference from the unity 1. If the because this is a ratio, so if the ratio is 1, it's mean the risk is same. Like for example, if I tell you, I give you an exposure to the smoking, or a person who didn't get an exposure to the smoking, both of them have lung cancer. So it's mean both have the same risk. So total risk, like number of the cases with the lung cancer with risk is 50. Number of the cases without risk is 50. So it's mean I can say this the total would be the 0. So you can see this the total if it is like 55 by 5, like for example anything like this. So the answer will be the 1. So if the answer is 1, so it's mean it's at the end it is showing you the same percentage. So it's mean there is no difference whether there is a risk or whether there is a not risk. So they give you another definition of absolute risk ratio also, whose reciprocal is number needed to treat. Number needed to treat should be provided only for the significant effect, because if it is difficult to interpret the confidence interval for non-significant result. So first you have to know whether the result is significant or not. Significant, p-values, all these things you will discuss in the biostatistics about the significant result from the confidence interval for OR and RR. If confidence interval contain 1, confidence interval is a interval. Interval mean it's a value of lower and the higher side, and it tell you that your mean fall in between these values. So like for example, the confidence interval is from 1 to 5. So if your confidence interval contain 1, mean the value will fall between 1 to 5. So if your confidence interval contain 1, mean the value will be start from 0.5 to 2.5. So it mean the confidence interval contain 1 in between them. Then this is a non-significant result. Then we don't see the alpha value. Normally we say alpha is less than 0.05, it is a significant value. But if there is no alpha, then we have to see the confidence interval. So confidence interval, we have to see whether what is the value in the confidence interval, then we will find out. So how to calculate OR, RR, ARR, and NNT? So this is the how you have to write the table. You have to see the disease, whether this disease is, for example, it's a myocardial infarction is there or no. Whether you have to see the smoking. Yes, he was a smoker. Yes, he's not a smoker. Then we see how many smoker got this disease, how many smoker didn't get this disease, how many non-smoker get this disease, and how many non-smoker didn't get this disease. So this is, you will make the table, and from this table you will get the value of OR, odds in case of case control, and RR in case of cohort study, and AR is absolute risk ratio. What is absolute? The rate, the risk ratio in the control minus risk ratio in the treated. So it will tell you the absolute value. So it is telling you if you are in a control group, like you are not in the without exposure, and if or you are not taking that treatment, and then you are taking that treatment, what is the difference? So the difference, it will be the absolute value. So this is the absolute value. So this is the absolute value. absolute risk ratio, and the this absolute risk ratio is the number needed to treat. What does it define as number needed to treat? We will discuss it later. So we will talking about the values and magnitudes. So if the RR or OR is less than 1, what does it tell? If it is 1, what does it tell? And if it is more than 1, what does it tell? If it is less than 1, then it's mean the association is lower. It's mean the odds of getting myocardial infarction through smoking is less than non-smoker. Like smokers have a lesser chance of myocardial infarction than that of non-smoker if the value is less than 1. If the value is 1, what does it mean? The odds of getting myocardial infarction is same in smoker and non-smoker. Okay. If the value is more than 1, what does it mean? It's mean the odds of getting odds of getting myocardial infarction in smoker is more than that of non-smoker. So now this is telling you the interpretation, it's telling you the value, but it's not telling you the magnitude. It's just telling you direction. It's less than it can cause or it cannot cause, but how much it can cause, that's very important. That's we will get through RR and OR. Value with the number of value. Like if it is 0.75, it's mean it's less than 1. So it should be lesser than, but how much lesser than? 25% lesser than. And if it is 1, then there is no, it's already mentioned, no association, no difference. It's already mentioned here. But if it is 1.5, it's been 1 mean no difference. So 0.5 means 50% more chances to get. And if it is 3, so 1 we will remove. So what is what it will be remaining? It will be remaining 2. So it's been 200% chances higher than that. Or we can say 3-fold higher than that. I hope till here you can understand everything. Here is a, yeah, it's we discussed about the PPA, hemorrhagic disease. You remember? So exposure is appetite suppression use, whether the patient is using or not. So there are women. We just see in the women. Yeah, they were using. How many women are using? 7 women are using. So 7 women are using a appetite suppression, but 6 get hemorrhagic stroke out of 7, and 1 didn't get. And 377 plus 749 total individual, they are not taking appetite suppression, but out of them 377 get the hemorrhagic stroke, and 749 didn't get the hemorrhagic stroke. This is the value. Now what is the odd of this disease? Now because this is a this is a case control study, so we will want to know the odds of hemorrhagic stroke. Like how much is it possible, or how much does it happen? So data from the PTA, so it is 12. So can anyone tell me what does mean by 12 if the OR is 12? Anybody can write, or anybody can say to unmute yourself. So can anyone explain what does it mean by 12? Are you with me? Yeah. Can anyone explain? Here, I have just explained it to you. In the last line, we just seen that. Yeah, here. Yeah, this is 3. OR is 3. So how many folds? 200%. So it's mean there is 1100% or 12 times, 12-fold chances of getting hemorrhagic stroke if you are using appetite suppression. This is how it is telling you the magnitude of the risk. So use of a PPA and appetite suppression, the risk of developing hemorrhagic stroke. Now this is in the case control study, but it's including the men. or either men or not. So here we have some confidence interval. Here I want to ask you something. Is this value is significant value or non-significant value? Can anybody tell me with the reason? If you are not sleeping, huh? Are you with me, or you want to ask something? You can just unmute yourself. You can talk and you can discuss with me. Yeah. Can anyone tell me this first value 1.51 to 182? This is a confidence interval. Okay, it's mentioned over there, 95% confidence interval. Whether this value is significant or non-significant, it's not giving you any p-value. So what does it mean? Can anyone answer? This is a significant value. How, Rida? How can you say this is a significant value? Yeah, because anyone else? Yeah, she's writing. Anyone else? The number of participants are just decreasing with the time, huh? Yeah. It lies within the range and it's more greater than OR, which was 12. No, 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 no. Significant value for um, confidence interval, I told you, if it is a ratio, it must not contain 1 in between them. So if it is starting from 0.5 to 182, it is non-significant. But it is starting from 1.5. So from 1.5 to 182, does 1 come between them? No. So it is coming from 1.51 to 182. So 1 is left behind. So it's mean this is a significant value. Always remember. Same like this. This is a significant value. This is still we can consider it is starting from 1. But this is not a significant value. This is starting from 0.2 to 1.92. This is not a significant value. And here, this is also not a significant value. So this is very clear uh, from the uh, confidence interval. You can get to know whether it is significant or it is non-significant. Okay. Can I move further? Is it fine? If you don't understand anything, you can just tell me. Okay, we talk about causality or causation. Uh, we will just see. Remember, in general, we do not prove or show causality with the observational study, but there is some general guidance to consider where evaluating them. It is important to recognize that in many situations, the conduct of the studies to establish causality is not possible, practical, or ethical. Obviously, you cannot find out. So what we should know about it, was statistical significance observed, whether we have see it is a significant or non-significant. We have to see the strength of association. Did we find out OR/RR? Because if we find out the OR/RR, we will get the strength. What the dose response relationship evaluated, whether we see how much increasing the dose can impact the response, what a temporal relationship between exposure and disease outcome. Have the result been consistent shown, while might be if there is one time it's not giving you the significant result? Is there biological plausibility to the association? Is there any experimental evidence? So this is the causality you have to find out. What it will help you, it will help you to tell you whether your study is good or not, or whether this study is good or not. So next we will talk about the sensitivity and specificity. Now, what is the sensitivity test for COVID-19 and what does it mean? Can anybody tell me? Yeah. Can anybody tell me what is the sensitivity test for COVID-19? What is the value? And what does it mean? I heard about 65%. Can you tell me what does it mean? You can unmute your mic. You can speak, no problem from my side. Yeah, Dr. Sumaya, Dr. Rida, anybody? Dr. Guls, if you want to tell. Okay, I have one message. So PCR is a test, but the value is something I'm not sure of. Okay, that's good. PCR, obviously, it's a test, and value is okay. I will tell you. Now, I'm saying sensitivity is not 100%. What does it mean? It's mean this test is not 100% sure that you are positive. So they are saying 67% chances is that the test is telling you the true value. 67% chances is that the test is telling you the true value. Why? Because it can be a, because this is a swab taking technique and so many things are there. So it's mean there is a chance someone is positive, but he will be PCR sensitivity test. Yes, sensitivity test. Yes, exactly. So sensitivity is telling you might be there is a possibility. Someone is positive, but we will not detect him positive. Someone is positive, but we will not detect him positive. Very critical word. Listen to me carefully again. Someone is positive, but you will not detect him positive. So it's mean he is true positive, but you didn't detect him. And it's mean this patient is false negative. It's tell you negative, but false. Actually, the patient was positive. So there are type of two type. If the patient is positive or if the patient is negative. So we will see what type of this is the patient. If the patient is positive, the patient can be true positive. Like patient is also positive and test is also telling you the patient is positive. But now there are some patients, they are actually positive, but the test is telling you they are not positive. So they are actually false positive. Okay. So same like this, false negative and true negative. So these are negative patient, and this is their true total this value of true positive and false negative and false positive and true negative. And here from here we can find out the sensitivity. From sensitivity point of view, we will take the true positive divided by true positive plus false negative. So it's mean it's negatively false value. So actually it's a positive patient. Actually it's a positive patient, but it tell me that he is negative. So it's a false negative value. So how the main question arises is there, how can I know this patient was positive but test is telling me the negative? Can anybody tell me? How can I check whether the testing kit is telling me the wrong? Actually, the patient was positive. So for these type of patient, we will see the symptoms. Whether the patient is symptomatic, we say him to do it to repeat the test after 1 day. You see why we are doing this? Why the repetition is there? Why? Because we are feeling this patient is actually true positive, but the result is negative. So this type of patient is the false negative, and this is actually true positive. So total value true positive divided by the total all positive is the sensitivity. Now specificity. Specificity is telling me how much my test is specific to this result. So in this, it is opposite to the positivity. In this, we will see how much patients are true negative. True negative mean they are actually negative, and test is also telling me the negative. And total divided by total number of negative. So total number of negative are false positive also and true negative also. False positive, true negative. So false positive is actually a negative. So this is same like mathematics, minus minus is plus. Same like this. So if we want to predict how much is the prediction value, we can use a positive predictive value. Same we can use the negative predictive value. And if we want to know the prevalence, how much total patient in our population, total population, how much are the positive? So we will divide total positive. So total positive are true positive plus false negative divided by everyone, positive, negative, everyone. So this will tell you about my prevalence. So prevalence is total population, how many people are positive. This is the prevalence. If you have any question for sensitivity, specificity, you can may ask. Sensitivity is a proportion of a true positive that are currently identified by a test. A test with a high sensitivity mean a negative test can rule out this disorder. Specificity portion of a true negative that are correctly identified by a test. A test with high specificity mean a positive test can rule in the disorder. Same predictive value, positive result who actually have the disease, proportion of a patient with a positive result who actually have the disease. So we will see how many people actually have the disease and they have the positive result. So same like this for the negative. So this is a predictive value. Now we will come to the last point. Last type of study is the randomized control trial. So we have the best type of study. Single study is the randomized control trial. This is experimental or interventional. So we do one intervention. We give some medicine to the patient or we make some changes. Like for it's not like observation, you're sitting outside and you're seeing how the patient is doing. No, it's like we will educate them and we will see what is the result of education. We'll give them food, we'll see what is the impact of this food. We'll give them this medicine, we'll see what is the impact of this medicine. So this is a randomized control trial, RCTs. So why we do randomization? Can anybody tell why we are doing randomization in randomized control trial?
Sir, just to decrease the biasness.
Exactly. Exactly. I don't know who is she, but very good,
I'm
very good
Sumaya.
answer. Yes, Maya, that's exactly. We were talking about the confounding factor and biasness. So we do randomization. Why? Because we want to reduce the confounding factor or biasness. So we have block randomization, stratification, cluster randomization. These are type of the randomization. No need to go into the detail, but you can study them also in the future as well. uh, Treatment control. We have a control group also. Why we have a control group? You remember I teach you restriction. So it's mean we have a group of people don't get this medicine. So we have restriction group and randomization. So restriction was also the part of to control the confounding and biasness. So we have placebo control, mean we are not giving him anything. Active control. Why we are giving the active control? Because we want to see whether might be the patient is taking type 1 medicine and he is taking type 2 medicine. So we will see both of them, like one we are giving diclofenac and the other we are giving brufen or something. So medicine is active, but it's we will take it as a control. So historical control mean it is from the history, it is from the past. We will see how much of these characteristic with this happen, we don't give them anything, so what does happen to these people. And then we have just a comparison with the same type of people with medicine. Okay, we blind it. It's a called blinding. Blind mean somebody don't know. Why we blind? Because it can cause biasness. Might me, I'm a researcher. I see one of my friend is there. I will give him a better medicine. I know this is medicine better than the other one. So I'm doing some biasness. So to reduce the biasness or to reduce this culture, we make blinding. So it can be a single blind, only researcher or only patient, any one of them. It's not always the patient. It can be a researcher as well. Might be we tell about the patient, this is your medicine you are getting, but we don't tell to the researcher what he is getting. Same double blind, both of them don't know. Triple blind analysis group also don't. One analysis group, small group also is there. They also don't know. And double dummy. What is double dummy? It's like, for example, I'm giving you diclofenac and giving them ibuprofen. So I will give you dummy of ibuprofen also, and I will give them dummy of diclofenac also. So both of them are taking, like, they don't know which one is ibuprofen we are taking and which one is diclofenac we are taking. Whether we are taking ibuprofen or we are taking diclofenac, they don't know. Both of them don't know. Why? Because both have the dummy, and one medicine is real, and I only know about it. Which one is real, which one is dummy. So I make you confused. I'm giving you both of them, and I don't know which one is true medicine and which one is dummy. And open label is obviously everyone know about what type of medicine we are getting. Open label has very low value. So we used to do crossover designs, and we are using this straight also, um, randomized parallel design also. So what type of this, like, we have a population, we have a study sample from which we give one patient intervention one, the other type of patient intervention two, and intervention one we will see the outcomes and not outcomes, and we will see intervention two outcome and not outcome. This is very simple. It's a parallel. They are moving parallel. But in the crossover, what we do, intervention one, in future they will get the intervention two, and intervention two they will get in future intervention one. So this is how we are making the crossover. But when we use the crossover, when can I use the crossover? When we have a sample size less than 300, or in comparing pain treatment, no time limiting, when we don't have a time limit, or we have in comparing pain treatment, like for example, uh, we don't have a lot of people less than 300. Okay, we will do crossover. Okay, we have a unlimited time to study. Okay, we will do crossover because it is time consuming. Now, in comparing pain treatment, this is very important. If we are doing a pain analysis, how we know diclofenac is better than brufen? How? Obviously, first we give it to the patient brufen, and the other patient we will give him diclofenac. And then when washout period mean when the body will be get rid of this medicine, we will give them cross medicine again. Then we will ask them whether first medicine was effective for your pain or second, and same question for the both of them. The both will say, the first will say the first medicine, it's mean diclofenac was better. The other will say no, the second medicine is better, so it's mean he's also saying diclofenac is better. So we have a double authentication from both of them. The diclofenac is a better painkiller than that of a brufen or Panadol. So example one, compare the effect of a tramadol to placebo in a painful, obviously in neuropathy. Compare the dose of a potassium salt to the diclofenac to placebo, 150 mg in the treatment of migraine, 3 dose of a new formulation. These are all like painkillers. Limitation kya hai? What type of limitation we have in a crossover design? Persistence of effect for the first treatment. If the treatment induced changes in the major outcome are not soon reversed when treatment is withdrawn, crossover designs are inappropriate. It's very inappropriate because of the persistence of effect. Because if you still have the effect of the first treatment, you cannot start the second treatment. That's why this is here, it will be fail. Rapidly changing underlying disease. The underlying disease is changing very fastly, very fastly. That can cause. And like for example, if you are treating the patient with any treatment in which the patient is deteriorating with the time, if you stop the treatment, we cannot give a crossover, we can make a straight only. So high dropout rate, the patient are like fed up with the things, like you are giving me this medicine, now you are giving, I don't want to take any medicine like this. So the patient is not happy with this and they drop out. So what is a subgroup analysis? Subgroup, we before starting a randomized clinical trial, because as a clinical trial, it's very expensive, and they run through an very expensive study, but very informative study, because we have to study everything, every aspect. We have to see all the confounding factors, all, we have to stop all biasness, everything. So before doing this, we start a small group. We run this practical in a small group and we will get to know what are our results. And from these results, we will apply this result on the future. So we will know how much people we need it, what type of study we can plan. It should be blinded or not. It should be double blinded or triple blinded or double dummy, crossover, parallel. It's all information we are getting from this subgroup analysis. Important part of the controlled clinical trial, they are overused and overinterpreted. This is a problem. Normally, because this is small number, sometimes we take their result too much serious. But actually, when we do a large clinical trial, they are giving another picture of this subgroup analysis. So composite endpoint and surrogate endpoint. Composite endpoint, what are these? Like these are the other element of a same picture. So we will see this thing, this thing, this thing, this thing happen, then it's mean this will happen. So composite are the primary endpoint is one of the most important decision to make the design of a clinical study. A composite endpoint combines several endpoints. Several endpoint will combine and it will make a composite endpoint. Like for example, cardiovascular death, non-fatal myocardial infarction, cardiac arrest with resuscitation. All of these things are same. At the end, your patient is hurting with your heart failure. At the thing, this is a heart failure, but the patient is not dying. So anything happen like this is a composite endpoint. So usually combine measure of a morbidity and morbidity and mortality. It's telling you about it. Now I will tell you about the surrogate endpoint. So nowadays surrogate terminology is very much useful now. Surrogate mothers and very much useful. So we are in this we are doing some test, and on these the basis of these tests we get to know the endpoint value. Like for example, if a patient have a higher LDL-C reduction is there or not. If the LDL-C is reducing, then I can see the patient is getting better. So cardiovascular death reduction is there. You got it now. If you have a high, if you have a lower LDL-H, it's mean the good cholesterol is getting low. So it's mean you have a high chances of cardiovascular death. So it's a surrogate analysis, same HbA1c, same like this. So these values will tell you this patient is going to be diabetic. It is going. We don't wait for the diabetes. I cannot wait for the patient heart attack or death or something. So I will just see that values and I will come to the conclusion. Blood pressure. The blood pressure is getting high. Okay, this is patient is going for the stroke. I don't want him to go to the stroke. I will take him to the emergency. So I will say this medicine or this study or this factor affect his blood pressure, but I cannot say I cannot wait for him for the stroke. So surrogate outcome do not always predict clinical outcome. It's very important. That doesn't mean you have a high blood pressure, you will get the stroke also. So short duration studies that evaluate the surrogate endpoints may not be large enough to detect uncommon adverse effect. So these are normally short studies. So there are some studies or some clinical trials. We have superiority, equivalence, and non-inferiority results, or we have the studies like this. So we have, if I want to tell you, like for example, we have diclofenac is superior than that of ibuprofen. How can I get to know? So we have to run a trial. So this is a superiority trial. It's designed to detect the difference between the experimental treatment. This is a typical design in a clinical trial. Equivalence trial. I say my generic is equivalent to your brand. So is designed to confirm the absence of meaningful differences between the treatment. Absence of meaningful differences. Like there are no meaningful differences between the treatments. A non-inferiority trial is designed to investigate whether a treatment is not clinically worse. It means my generic is non-inferior to your brand. It's what does it mean? It is lesser than that, but not inferior, not to treat the patient. So the value should not be lesser than 13%. Like if your result, if your medicine is giving 100 mg and my medicine is giving 95 mg, okay, yeah, 95%, your medicine is giving 100% result, my medicine is giving 95% result, it's fine. 5% difference. We are non-inferior to you. But if it is more than 13%, like if it is 85%, okay, we are inferior to you. That's these are the type of studies. So you can see one of the observational study that found low rates of coronary heart disease in a post-menopausal woman who take estrogen. I have already mentioned this to determine the estrogen plus value, and this is randomized, blinded, placebo controlled secondary prevention trial. So see the name of the design. So how they are designing this type of studies. So total of this woman with coronary disease at younger than 80 years. So younger than 80 years mean to say there are some inclusion and exclusion criteria. And post-menopausal with intact uterus. So if they don't have intact uterus, we will remove them from the study. Mean age was 66.5. So intervention what we do is this: we give this conjugated estrogen plus this medoxyprogesterone acetate in one tablet or placebo of identical appearance, and we will see what is the impact. So 1380 we give this, 1383 we give this. Follow-up average 4.1 year we give a follow-up. So you can see how much expensive this study is. Of these designed to hormone treatment were taking in at the end of 1 year and 75% at the end of 3 years. So main outcome, the primary outcome was the occurrence of non-fatal myocardial infarction. Does this hormone replacement therapy causing myocardial infarction or not? We will study this. So there are some approaches for analyzing a clinical trial, because in some of the clinical trials, some people they left the clinical trial or they left the study with the time, while the other people they are not leaving the clinical trial. They complete the clinical trial, while there are some people who get the treatment of another group by mistake. So we say intention to treat analysis. If it is written in the results section, intention to treat analysis is mean we include everybody. Like for example, I take 100 people for my clinical trial, and out of these 100, like half of them has half of them or 50 or 10 of them didn't take medicine properly. Now actually 90 people take it appropriately, but these 10 people, what to do with them? Whether I have to include them or I have to exclude them. If I include them in the result, this is intention to treat analysis. My intention is to treat. Just remember, just for the sake of remembrance, my intention is to treat these 10 people. I'm just telling you for the sake of just to remember. It's not actually. So intention to treat analysis. So determine the effect of the treatment under usual condition of use, analog to routine clinical practice in which a patient receive a prescription but not adhere to the drug. Still, I am including this patient. This is my patient. This is intention to treat. Give a conservative estimate of a difference in the treatment. May underestimate treatment benefit. Obviously, these people didn't get something, so there is a possible you will not get the result as good as it should be. Per protocol analysis. Now I don't include them. As per protocol, what is the protocol? Protocol say how much people are adhere, include them, otherwise exclude them. So per protocol, as per the protocol. So this is very important. Do not adhere to locate to allocate treatment are not included in the final analysis. Only those who completed the trial and adherence to the protocol. Provide additional information about the treatment effectiveness and provide more generous estimate of the difference between the treatment. Subject to several issues because of the factors such as the lower sample size and definition of the adherence. And results are more difficult to interpret because here the number of people are reduced. It is from 900 to 95. In the last, it was 100. Here you can see it is 100, 40 out of 100, 50 out of 100. But here 50 out of 95, 40 out of 95. As treated analysis might be one of my patient will get the treatment of another group. So the subjects are analyzed by the actual intervention received. What type of intervention? If a group B person, he get the treatment of group A, we will treat him as a group A. So as treated, as the patient is treated. So here if the subjects were in the active member of the group but do not take the active treatment, the data would be analyzed as if they were in the placebo. Like the patient should have to take a medicine, but the patient didn't take the medicine. So it means he's on the placebo. We will take him to the placebo side. So as treated. So he is not adherent, we will put him in the placebo side. So this is more easier. So this analysis essentially ignores the randomization process because obviously I break my rules because I know as per the randomization I have to make them 50-50. Why I make it 60-40 now? Why I make 5 people, these 5 or 10 people who are not adherent to medicine, why I put them to the placebo group? This is why. Previous example of 50-90 and 40-90 and placebo from 110. So this is the difference. So these 10 people who are lesser than here, they are more than here in the placebo group. I hope you understand. So there are some systematic review and meta-analysis. These are the actually mixtures of the studies. What we do in the systematic review, we take same type of study. Like for example, we will see the brufen causing renal failure. Okay, we'll see this study in Europe, this study in Europe, in other country like Spain, in UK, in America, in different hospital again, in US, in UAE, in Pakistan, in India, in Europe, like this. So what I will do, I will collect all these studies in the different countries, but the study is same. What they do, they see the impact of the ibuprofen on the renal failure. So all these studies were same, but they are in the different regions, in the different settings, in the different areas. So what I will do, I will collect all these results, I will make a mixture, and I will get a mixture of all these studies. This is called a systematic review and meta-analysis. If you just write it without numbers, you will just see, you will just say in America, the renal failure is higher than that of UK or something like this. It is a systematic review. But if you are telling in America, it is 70% higher than that of UK, you are using the numbers, then this is not more systematic review. This is a meta-analysis. So there are some pharmacoeconomics definitions. It's very important. Normally 1 to 2 questions only from these definitions. Only from these definitions. So first is the cost minimization analysis. Difference in cost among the comparable therapies. Like for example, if I give you 2 therapies and I know this therapy is treating you in a lesser cost. So this is a cost minimization analysis. Only useful to compare the therapies which have similar outcome. So I give you a therapy 1 for your diabetes and therapy 2 for your diabetes. Both are giving reducing your HbA1c and both are reducing your glucose level. But which one is more lesser cost is the cost minimization. Cost minimization analysis. And which is what is the cost effective? It will give you what is the effect on your life. So year of life saved. If in your question it is mentioned this much year of life saved, then this is just blindly click cost effective analysis. This is the effect of the cost because this money is used to save your life. So number of symptoms free days, blood glucose or blood pressure. So if I spend some money to reduce your blood sugar, if I spend some money to reduce your blood glucose, it means this is a cost effective. This is the effect on the cost. So the cost is effective and cost utility and cost benefit are remaining. So cost utility is a quality adjusted life here. If they say QALY, quality adjusted life here, just click cost utility analysis. Normally these questions very confusing. That's why 1 to 2 questions every year they are asking. So assign the utility weight to out impact on the measure in relation to the cost. Compare outcome related to the mortality when mortality may not be the most important. So it is comparing with the mortality, but mortality is not the main outcome. And the remaining is always cost benefit. What is the benefit of this cost? Like for example, I make this building, I give this money to the doctors, and what is the benefit? What is the benefit? Monometry value is placed in both therapy cost and beneficial health outcome. Always analysis of the both cost of treatment and cost save the beneficial outcome. So I spent $1 billion. So how much? What is the benefit? So you tell me, sir, we have um, this much diabetes patient treated, this much systematic patient treated, this much cancer patient treatment. So there, this is the cost benefit. So, but if you say quality life here, then I will say this is the cost utilization. If you say quality year of life saved, this much glucose reduced, this much blood pressure reduced, this is the cost effect of cost. And what is the cost minimization? I take 2 treatments. This treatment is lesser than that. This is the cost minimization. If you have any question, you may ask right now. No, otherwise I'm going forward. So IRB review, I think so. All of you 12 people were there during the Dr. Asif lecture. This is, I have tell you about institutional review board. This institutional review board is present everywhere in um, a research organization. If it is a hospital, they have IRB. If it's a research organization in a university, they have IRB. So this is made up of 5 people. These 5 people, they are belong to different, there is one researcher, there is one non-researcher, one is a layman, and someone is out of your organization, and one is the practitioner. So these 5 people is made up of review board, and they exempt, if you want exemption from review board, if you want expedited review, or you want full review. But what type of research is that? Depending upon this, I have already teach you during the Dr. Asif lecture. If you want to see the detail, it's already there. We will share this presentation with you. So here you can see what type of expedited review and exemption review and full review. Here are my research. You can see this is a systematic review, and I am the author. A study of prescribing pattern of antibiotic in outpatient and emergency department in Gulf region, where I have an Oxford Journal of Pharmaceutical Health Services research. I have an meta-analysis. Here is the impact of pharmacist-led services on the antimicrobial stewardship program, a meta-analysis on clinical outcome. Where I have one more meta-analysis in the European Journal of Hospital Pharmacy. This is under the British Medical Journal, BMJ, evaluation of inappropriate antibiotic prescribing and management through the pharmacist-led antimicrobial stewardship program. So here we have, if you have any question, you may ask. Thank you very much, Dr. Gul. If you have any question, I have actually 4 total research article as a first author, and I have 3 to 4 article as a second author. I'm reviewing the researches also, I'm reviewing the articles also. I'm giving the suggestion to my professors. I'm very thankful to them, Dr. Wasif, and I'm very thankful to Gulf Medical University. They helped me a lot. So if you have any question, you may ask. Otherwise, I will go to the question answer session. You have any question? You just open your mic, no problem, no need to hesitate. We are just in a class and it's very friendly. We are all people are educated. Don't worry, no need to hesitate. You may ask anything. Otherwise, I will go to the question.
Assalamualaikum, sir. I have one question for you. What would you suggest an early research paper writer to, design his study on? Like, what kind of study is suitable for an early research paper writer?
Okay. Who is this? Can you tell me your name?
Rida, sir.
Okay, Rida. So, Rida, actually, first of all, I will recommend you to study the research. That's very important. Take out some articles that I teach you. Now you get to know the type of research. So take out some first case reports, take out some case control, cohort, cross-sectional, RCTs, then study them. Try to know the scientific language, what they are telling, why they are telling, first of all. Second is that see your specialty. If you are specializing in infectious disease, if you're specializing in cardiology, then study the articles related to them. But how you can study the articles is a very important question. So what you will do, you will find out the journals which are related to the like for example, if you want infectious disease, you try to study the Journal of American Journal of Infectious Disease or something like this. So if they have recent articles, just read them, and then you will try to create something in your mind, like this happen or this study is done or not. Then obviously if you have a background knowledge, in some article it is mentioned it is still undiscovered. So if if the article is telling that this is still undiscovered, it's mean you have an opportunity to discover it, so you can start studying. Then you first have to get the background, and I would like you to write a review first. So
Okay.
first thing that you can do is a case report, case series. If you are working in a hospital, if you are not working in a hospital, you are just working in a university, then you can do a review article, like a
Sorry, sir.
systematic review.
If I am working in a hospital, what can I do then? A review
Case
study or a
reports,
case report? Okay.
case
Okay.
report, start with the case, because this is the easiest and the simplest study.
Okay.
So if you
Okay.
want to enter into the studies, so enter from the case report, then you will explore everything. So then you can go to the reviews, or then if you have a PhD scholar, or if you are doing some high level research, obviously then you will come to the case report, cohort, or um, you can do any sort of like this what you say, this randomized control trial. But if you are a student and still you want to do some observational study, then you have a retrospective study. You can do case control or cohort. How you can do that, this I will give
Okay.
you an example.
Sir, is it okay to, write as a solo author, or do we always have to, have one person along with us to write the research paper? Would that be acceptable if I just write it on my own?
This is best if you do it everything on your own, but to
Okay.
have your friend with you, it will help you for analysis. Like for example, if you are not good in observation, you need a
Okay.
good observer, you need a partner. If you
Exactly.
are not good
Exactly.
in analysis, if you are not good in analysis, you need my help for analysis, then you have to write me as a second author. If you need
Okay.
anybody statistician, might be you don't need you cannot use SPSS, might be you cannot take out the values, or you miss something, so you need a statistician. Might be you are not a good computer worker, like you cannot bring out the articles for the background introduction and all these things. You need the references, you don't know how to do it, so you need somebody like this. So this is a team, it's a teamwork.
Okay. Okay.
But if you can
Okay.
do everything, then you don't need a team. Then this is perfectly all right.
Thank
Then
you,
this is
sir.
perfectly all right. Yeah.
Thank you so
So
much, sir.
you welcome, Rita. If there is any other question from anybody else, I love to answer. Otherwise, I will proceed to the questions. Yeah. So nobody. Okay. If you still thinking about the question, you can start thinking. At the end of the question answer, we will discuss about it. A recently released statin is associated with a less myopathy than other currently available statins. Okay, so I get to know one new statin in the market, it causing less myopathy, because the statins cause myopathy. After 2 years of a use, a retrospective case control study was undertaken. Case control, okay, was undertaken by the manufacturer. After 20 different reports of the several myopathy were sent to the US Food FDA MedWatch program. You remember FDA MedWatch program for the side effects? You remember the Dr. Asif lecture? Risk factor for statin-induced myopathy were not assessed. However, both the cases and the control of the study had identical diagnostic evaluation and were stratified according to the duration of the statin use before the onset of myopathy. Which type of bias in the study most susceptible to? Yeah, can anybody tell me? What type of bias is there? Yeah. No? Yeah, there is one answer. Okay, B. Recall bias. Sumaya, C. Diagnostic bias. No, diagnosis was fine. Okay, obviously it's cause statin, but see, they are saying case control study. It's a retrospective study. So in retrospective study, I told you always recall bias. Okay, which factor will be the most affected by the type of the bias likely to occur in this study? External validity, internal validity, assessment of exposure or number of the patient needed to for the study. Yeah. Question number 2, internal, external assessment of exposure or number of patients. Okay, Gul's number again, internal validity. Rida, internal validity. Why? Biasness, not external. No RF, not external. Why internal? Biasness. If something is affecting on the biasness, what does it mean? It's mean the biasness. I told you the confounding factor biasness, it cause effect on internal validity. Always remember. Okay. A letter published in a journal suggested that the established antipsychotic drug may cause photosensitivity. Okay. Adverse effect study kar raha hai. May cause photosensitivity. The manufacturer wishes to set up study to determine rapidly and efficiently where it is. Which of the following is the most appropriate? Case control, dose ranging study, double blind RCT, or meta-analysis? Case control, Gulsnober. Yes. Anybody else? RCT possible? Why not RCT? Meta-analysis. Okay. Meta-analysis. Okay. So guys, here the answer is, first of all, what he want to study. Efficient and quick result. Exactly. Meta-analysis is not for the efficient and quick result only. The problem is that meta-analysis is telling you everything about it. It's not only one thing. First of all, this patient is about antipsychotic drug may cause photosensitivity. It means they are studying adverse effect. So adverse effect mean exposure. What is exposure? Exposure is antipsychotic, and that exposure can cause a disease or can cause a problem, and the problem is photosensitivity. So we are seeing the patient with photosensitivity, without photosensitivity, and we will go into the backside whether they have used this antipsychotic or they don't have used this. So it was very fast and cheap. You remember, it was already mentioned case control study. So this is a case control. Okay, approximately 40,000 subjects with acute myocardial infarction were randomized to the 4 thromboembolic strategies in an open label fashion. What is the primary fault in this study design? Lack of placebo, lack of investigator blinding, presence of historical control, presence of selection bias. Presence of selection bias. Okay. Anyone else? Lack of placebo. Is it possible? Can we give placebo for MI? Obviously, we cannot give placebo for MI. Patient will die. Okay. Presence of historical control. Historical control का यहाँ पर कोई किरदार नहीं है. It's not working there. Presence of selection bias or lack of investigator blinding. RCT should have RCT should have randomization. And second thing I told you, blinding. Is there anything blinding? Lack of investigator blind. So it should be blinded. Okay. Then a multi-center double blinded, placebo controlled trial, randomly assigned. So it's a RCT, complete RCT. 4,837 patients to the treatment with migraine supplement with omega-3 and alpha-linolenic acid, or a placebo margarine. So there is a margarine supplement with omega-3 and alpha-linolenic acid, or there is a placebo margarine. The primary combined endpoint was the rate of cardiovascular event, defined as fatal and non-fatal cardiovascular event and percutaneous coronary intervention. Data were analyzed according to the intention to treat analysis. You remember intention to treat analysis? The use of Cox proportional hazard model, the hazard ratio, and 95% confidence interval for the margarine and alpha linoleic acid group were 0.9. So answer is 0.78 to 1.07 is confidence interval respectively in the pre-specified subgroup of women. Margarine with alpha linoleic acid was associated with hazard ratio is 0.73, which is confidence interval 0.51 to 103. Which statement is most appropriate? Margarine with ALA statistically significant, reduced risk of cardiovascular event. Margarine with ALA statistically significant, reduced risk of cardiovascular event. Margarine with ALA do not statistically reduce the risk of cardiovascular event. Without a p-value, it is impossible. Yes. Very good, cool. Because it contain 1. So answer is only C. So without B, still we can know whether it is statistically significant or not. Very good. Okay, question number 7. When the study was being designed, the choice described the outcome of which study was most likely to be powered. Differences in the rate of composite outcome cardiovascular event, differences in the rate of percutaneous coronary intervention, or differences in the rate of composite outcome in women, or differences in the rate of composite outcome in men. When the study was being designed, which choices describe the outcome for which the study was most likely to be have powered? So how can we increase the power? Answer is A, differences in the rate of composite outcome and cardiovascular event. So how much are the composite outcome and how much are the cardiovascular event? We'll see in a meta-analysis of a studies examining the effect of a several antihypertensive drugs, the odd ratios of the treatment with the low dose diuretic compared with calcium channel blocker for cardiovascular disease event was 0.8. Confidence interval is this. Which statement is the most appropriate in intervention? Okay, odd ratio is 0.84. Okay, a treatment of hypertension with the low dose diuretic was effective, or treatment with hypertension with calcium channel blocker are more. Just a minute, what happened to this? Okay, a treatment of hypertension with a low dose diuretic Yeah, I will elaborate. Just a minute. Where is my presentation? Okay. Uh, so meta-analysis study in which several antihypertensive drug the odd ratio for treatment with low dose diuretic compared with calcium. तो हमने क्या किया है कि लो डोज डायूरेटिक को कंपेयर किया है कैल्शियम चैनल ब्लॉकर के साथ, ठीक है. तो इसमें जो है हम इसमें देखेंगे कि ये कौन सी जोन सी है ना मेडिसिन उसको ज्यादा वो odds of event किस में ज्यादा है. Treatment of hypertension with low dose diuretic was more effective in preventing cardiovascular event than treatment with calcium channel blocker. Treatment of hypertensive with calcium channel blocker has more effective in preventing cardiovascular. वो cardiovascular ज़्यादा कर रही है. The difference observed treatment with calcium channel has and low dose of diuretic is not statistically. Is it statistically significant or not? It is statistically significant. The odds of developing cardiovascular event when treating the hypertension with low dose diuretics are lower than using the calcium channel blocker. Yeah. So tell me. What is the answer? Yeah. Okay, Gul said that 1A and Sumaya said C. Not statistic. How Sumaya it is C? Is it not statistically significant? How? There is value of 1. Is there a value of 1? Then how it is C? A. Exactly. The answer is A. Because it is telling you the treatment, because I told you if it is less than 1, its mean association is lesser. So it is lesser than that of the low dose diuretic is lesser than that of calcium channel blocker. Yes. So a prospective randomized trial is there. Study compare once daily enoxaparin with twice daily enoxaparin when treating the patient with venous thromboembolism. On the study endpoint was recurrence of VTE, venous thromboembolism. Um, the following table summarizes the reoccurrence rates in all patients. So you can see the all patients, out of which 13 have once daily and 9 are twice daily. The 95% confidence interval for the difference in reoccurrence is minus 1.5 to 4.5. So twice daily is superior to once daily. Superiority of twice daily enoxaparin could not be established. Once daily is not inferior to twice daily. No conclusion can be drawn because p values are unavailable. Yes. B. Exactly. Because we were trying to find out the superiority. Whether it is superior twice daily. No, it is not no more superior. Okay. According to the data in the previous question, the result obtained which represent the number of the patient who have needed to be treated with twice daily enoxaparin to prevent the reoccurrence of 1 VTE. So number needed to treat would be 2. NNT would be 67, NNT would be 152, or NNT would be calculated because the result was non-significant. Exactly. I told you, we cannot find number needed to treat. So what is actually number needed to treat is, if you want to treat one patient, so you have to give this medicine to this much number. Okay. So if it is number needed to treat is 2, then it's mean 2 people I will give medicine to treat one patient at least. So if it is non-significant, then how can I treat it? So question number 8. When describing the result of a randomized control trial, the investigator report using an intention to treat analysis to analyze their data. The result of their investigation comparing the two diuretic for the heart failure show no difference in number of hospitalization. No difference because comparing two heart failure for decompensated heart failure between the treatment group. Given their method of data analysis, which treatment is most appropriate? May be susceptible to issue regarding recall bias. Is there any chance of recall bias in RCT? No. Provide a good measure of effectiveness under typical clinical condition. Cannot provide an estimate of a method effectiveness. May overestimate the actual treatment effect. Yeah. What did you think? Yes, exactly. B and D. Okay. Okay. Anything else? So we will see whatever presentation was saying. Yes. Here. Compare outcome on this under usual condition of use analog to routine in which a patient receive a prescription but may not adhere to the drug gives a conservative estimate, may underestimate the treatment benefit, may underestimate the treatment benefit. So where should I go? Tell me. Yes, it will go with the B, not with the D, because it's not overestimate. It's an underestimate. So we will go to the last question. According to the Code of Federal Law, which statement describe the what is required of IRB membership? At least one layperson must be there. I have told you. Yes. The size of the IRB changes depending upon the institution size. No, it will remain same. You have a bigger institute or lesser, it will remain same. At least 10 members serve on the IRB. No, it is 5. There must be one physician in the IRB. Chairperson, it is mentioned a practitioner, not physician. Chairperson, one scientific member, one non-scientific, and one lay person unaffiliated with the institution, and a practitioner. Okay. As a resident who recently complete a research project, you are writing an introduction section and section of the paper. Which piece of information would you be included in this section? Information related to the process of selection of the patient, summary of the prior studies, average age of the study subjects, or acknowledgement of the clerical staff. Yes, what you will write in the introduction part? Tell me. B, summary of the prior studies. Exactly. You have to tell the background. What is the history? What the history is telling you? Okay. So today part is over. If you still have any question or if you still have any queries, you may let me know. Otherwise, I'm going to close the meeting. Yes. Thank you very much, all of you. Thank you very much, Dr. Gul, and thank you very much, Abdul Rashid, for your nice comments. Thank you very much, everyone. These recordings will be shared with you soon, inshallah.